As a dietitian who works with CKD patients, when we conduct nutrition assessments, we really need to keep in mind that CKD patients are at a higher risk for malnutrition. So protein energy malnutrition is very common, especially in those patients who are already on dialysis. And due to the fluid shift and electrolyte imbalance and other metabolic aspects, many lab values will be affected. The problem in nutrition diagnosis, so a lot of the problems are associated with malnutrition, as we will see, and because of the complexity of the condition and the complications and impacts of the treatment, many diagnoses are valid and possible. So of course, that means we really need to apply our critical thinking skills in order to prioritize nutrition problems. This is a very good table that summarizes the factors that lead to malnutrition in CKD patients. So please study this carefully, but I do want to mention a few important things. So if we recall, when we had talked about malnutrition, compromised dietary intake is one of the leading causes for a diagnosis criteria. So let's see about the intake in CDK patients. We may see things that could affect food intake. So due to the accumulation of toxic metabolic waste, patients may have nausea and vomiting. Also, their taste may change. They may feel tired. And as a result, they may have anorexia or whatever they prefer when they were fine, doesn't taste the same now. So appetite will be decreased, and association with food intake will decrease as well. So we can see it's multiple factors contributing to a lower intake. Other things that contribute as well is not just the disease, but also the treatment. For example, dialysis itself can lead to systemic inflammation. So increased inflammation, which would increase the energy requirements, among other things. So we have low intake and high requirements, and that's a combination that can push people towards malnutrition. And the other factors mentioned on this slide should hopefully make sense and be understandable, so please read through after class. So similar to medical treatment, the nutrition intervention of CKD patients also depends on what stage they're at. So depending on whether they're early, late, or pre-dialysis, we do need to focus on the specific comorbidities. For example, the causes of CKD, so things like hypertension, diabetes, obesity, lipid disorders, all of these should be adequately addressed with the help of nutrition therapy, because otherwise, if we're talking about a pre-dialysis patient, the loss of their kidney function will be accelerated if these conditions and diseases are not well controlled. So the dietitian really has an opportunity to frequently follow up with these patients. And this would be the case if the patients are on dialysis, because they're already going to the dialysis center for 3 times a week on their regimen. And so the dietitians at these centers could see the patient frequently and be able to closely monitor everything. For pre-dialysis patients, we again follow the National Kidney Foundation guidelines, so those KDOQI guidelines. And also we have specific guides for CKD patients by the Academy of Nutrition and Dietetics. Overall, once they reach stage 3 and stage 4, protein restriction is indicated. So with this principle, we want to provide adequate energy to prevent malnutrition and also provide adequate protein to maintain muscle mass and serum protein level. Because, for example, if we can maintain serum protein levels, that could help us reduce edema, right? So reduce fluid retention, pull more fluid back in. But of course, we don't want to overwhelm the kidneys and provide too much protein either. And if there are micronutrient deficiencies, we really need to assess this with caution because certain supplements for minerals, we really don't want our patients to be touching, as we'll see later on. We also want to normalize blood lipids, and this would be because of things going on with the treatment and also precipitating conditions that may have led to CKD. So many CKD patients have abnormal blood lipid profiles, and that's something that we do need to be paying attention to. Once they reach stage 5, either hemodialysis or peritoneal dialysis, once they're undergoing those, they really need to focus on getting adequate nutrition intake, and in this case, high protein. So at this stage, there's no point in restricting anymore because the kidney function is already gone and the treatment regimen itself increases the need for protein and energy. But at the same time, we need to control, limit, and monitor certain minerals. So the nutrients for stage 5 patients that we need to monitor include protein, sodium, potassium, phosphorus, calcium. We need to watch their fluid intake and sometimes other minerals and vitamins as well as fiber. As far as the fat intake is concerned, we already know that high fat intake increases the risk for heart disease and stroke, and a lot of renal patients are at an increased risk for these diseases. And people on hemodialysis typically have normal LDL and HDL triglyceride levels, but for patients on peritoneal dialysis, if you recall, because we have that extra dextrose in the dialysate, which is put into the peritoneal cavity, and then we absorb part of this dextrose. So with that, this could push patients to have high blood lipid levels, as well as high total cholesterol, LDL cholesterol, all of these can increase. And because of this, what we learned, what was discussed with atherosclerosis, the TLC diet, remember the therapeutic lifestyle changes diet, really could help managing in the abnormal blood lipid levels in stage 5 patients. So here we have a table in the textbook that summarizes the current recommendations for CDK patients. And as we can see, the recommendations are divided out based on the type of disease. So if it's acute injury, early pre-dialysis stages, or end stage if they're on hemodialysis or peritoneal dialysis. For each one, there will be indications based on their pathophysiology at that stage, and as well as the medical treatment they would be receiving and how their labs could be affected. So if we look at the protein requirements, if we're looking at CKD stages, we can see that if it's early stage, we're basically at the adult RDA or higher, which is okay, but once we reach stages 3 or 4, we need to be restricting protein intake. So it's either at the DRI level or slightly below. And then once we reach the stage where dialysis is needed, the restriction is removed. So we can give high protein allowance based on the ideal body weight, or here we see SBW, standard body weight, which is just another term for ideal body weight. In addition, please pay attention here. The HBV stands for high biological value, and this is a marker to describe the quality of the protein. So that means although total protein intake is necessary to be increased in dialysis patients, We also need to be paying attention to the quality of the protein. So at least half of the protein they're consuming should be of high biological value, which means that these proteins, which are usually from an animal source, they tend to have a very similar amino acid ratio in comparison to the ratio in human protein. Therefore, these proteins will have higher efficiency of assimilation once inside the body. This means that there will be less disproportionately provided amino acids that will have to go through the deamination and urea synthesis, because right now we have that compromised kidney function or kidney failure, and it would be difficult. We really can't get rid of nitrogenous waste, which includes urea, efficiently when we're relying on dialysis. So if we're getting a lot of this nitrogenous buildup, then in between dialysis episodes, this buildup could be so fast and it can affect the patient's health. So please pay attention to this. Then we can see for energy, once they reach the dialysis stage, energy allowance here is much higher compared to the first 4 stages. And in both HD and PD, people younger than 60 years are going to have a need for more energy, because we know younger people have a higher basal metabolic rate, and also younger people tend to be more physically active as well. So this is going to call for more energy intake. And then if we look kind of overall at the minerals we were talking about here, a lot of this calls for the monitoring of their serum levels. So adjusting to based on what their serum levels are. For example, potassium, phosphorus, all of that will need to have a lab value. So, if we're deciding whether to restrict intake or how much to restrict, it's going to depend on the patient, how the patient is handling it, where the patient's standing at now. Then for fluid intake, that depends on which stage, of course. For example, if you look at, for stages 4, we typically don't limit that for 4 or lower. But once the patient has edema in stage 5 and they're on dialysis, the fluid intake is going to be based on urine output. So we would have a different limitation strategy depending on how much urine output the patient is producing. And some other vitamins and minerals are shown here, so you can keep this as a reference. And we do need to adjust body weight for both the obese or underweight patients. And this slide here shows the strategy on how to adjust the body weight. And again, standard body weight here is basically another term for ideal body weight. And we'll need to have the ideal body weight, which we know how to calculate from the Hamway equation. And we'll want to have edema-free body weight. So another term for this is estimated dry weight or just dry weight. So this would be the patient's weight without fluid overload. So how do we get the dry weight? Well, we could ask the patient how much they weighed before they became ill. So the usual weight would be before the fluid retention started, and that could be a way that we find out. But if we're talking to someone who's been on dialysis for a long time, like for example, if we have a 65-year-old patient who's been on dialysis for 20 years, asking them how much they weighed at age 45, so like 20 years ago, that weight is probably not going to be accurate and reflecting their current dry weight. So in this case, since the patient's on dialysis, every time he goes into the dialysis center, the nurses will take their weight both before, during, and after dialysis, or at least before and after. So therefore, the post-dialysis weight in this case would be more accurate to be used as a dry weight. So once all that excess fluid has been removed after dialysis, we can use that weight. We can also find it through weight history in the chart if we need to. Also, if the patient is newly progressing towards stage 5, so if we have, someone who's maybe stage 4 but is almost meeting stage 5 criteria, and they reported that they really quickly gained maybe 6 kilos in the past few days or past 2 weeks, we know that it's pretty unlikely that someone would have a 6 kilo gain of fat over that time span. So this would probably be water weight. So remember, the overwhelming concern for CKD patients is malnutrition, not overnutrition. So they may be overnourished to begin with. That's why they go down the path. They get the obesity, type 2 diabetes, and renal failure. But once they reach the CKD, their stage is going to be, at that stage, their concern is going to be malnutrition. So if a CKD patient told us that in a short amount of time, they've gained a significant amount of body weight, then that gained weight is usually fluid. So we would want to subtract that gained weight from their current weight. And that would be another way to estimate their dry weight. So please pay attention to also the indication for adjustment, so when to adjust. And we'll want to do that when the patient's weight is below 95% of ideal body weight, so meaning that they're underweight, or above 115% of the ideal body weight. So either if it's too high or too low, we need to use this to adjust. We mentioned that many CKD patients have high lipid blood profiles, therefore the TLC diet is helpful. And again, this is the same TLC diet that was talked about during the cardiovascular disease module last semester. In terms of fluid and sodium, we already mentioned that based on the stage, and in the case of dialysis patients, the actual urine output, then we would have different limitations. And you've actually already had a list of high sodium and low sodium foods, as well as high potassium and low potassium foods when hypertension and heart failure were discussed. So those lists would still apply in this case. And also during that time, there were similar tips of something we can use in nutrition education, the nutrition counseling of renal patients. So these include practical tips to help the patient meet their fluid restriction or sodium restriction. So these are very useful tips that we should, be able to know off the top of our head. And so when we're working with renal patients, we can confidently recommend and reinforce the patients to use these tips so that they have better compliance with their diet. For potassium, we mentioned that due to the decreased excretion of potassium through urine, patients tend to have hyperkalemia, and that's why we would need to restrict dietary intake. Otherwise, hyperkalemia could lead to cardiac arrest. And there may be those of you who have experience in a food department at some facilities. And, if there is a meal ticket that is for renal diets, then that would be an indication to make sure that there's no things like tomato, no potatoes, no orange juice, things like that on the plate, because those would be high potassium items. So we would need to replace it with something else. For example, mashed cauliflower is often used in place of mashed potatoes. So phosphorus is a very prevalent mineral in different food sources. So it's found both in animal and plant-based foods. So therefore, we almost never see someone with a phosphorus deficiency. Really, there's just kind of no such thing. On the other hand, right now, with chronic kidney disease, urinary excretion is compromised. So that means it's really easy for us to be getting rid of too much phosphorus in the system. It's really easy for us to build up too much phosphorus in the system. So this is why this mineral needs to be restricted. And the National Kidney Foundation has published a book that lists foods that are high in various minerals, and phosphorus is one of those minerals. So it's a book that can be used by both professionals and patients with all the foods listed. And one thing I do want to point out is for dairy products. And we know dairy products are a good source of complete protein with high biological value. It's also a good source of calcium and vitamin D if it's fortified in the US. But dairy products are also high in phosphorus. Therefore, CKD patients need to try to limit their dairy intake. And this is different from liver failure patients. Recall that for liver failure patients, that because of the compromised liver function, we have too much aromatic amino acids, and the metabolism of them can damage the central nervous system. So basically, this is one of the things that may lead to encephalopathy. But in that situation, in liver failure, dairy products are actually encouraged and promoted because it has more of the BCAA, the branched-chain amino acids, so therefore it generates less neurotoxic effects. But for renal failure patients, this is not the case. So for the sake of limiting phosphorus, we need to watch and limit dairy product intake. Another thing about phosphorus is that because it is so prevalent, it is very difficult and challenging to modify the diet to really limit the phosphorus intake at this level of 800 to 1,000 milligrams a day. In reality, once we calculate everything, if all the other markers we check are met, so we're meeting the levels for other minerals, protein, fluid, energy, and they're fine, but the phosphorus may still be over 1,000, then we could recommend that the patient's doctor use a phosphate binder. And that's because this is a medication that they can take to decrease the bioavailability of the dietary phosphorus. And again, in this case, we wouldn't want to recalculate again and again what the needs are or the diet, because it's just sometimes we're just not able to reach this low restriction for phosphorus with dietary modification. So for calcium, usually the limit is 2 grams per day from all sources. And we need to remember that certain foods high in calcium often have high phosphorus contents. So if they stay away from those, they're hitting both of those minerals and keeping them limited. So if our bodies cannot properly handle the calcium, then it can cause calcium deposits in blood vessels, which contributes to heart disease. Again, this is for calcium from all sources, so foods, supplements, and also we need to keep in mind that some over-the-counter medications may contain calcium, such as antacids, things like Tums, which is calcium carbonate, and also some of the phosphate binders may contain calcium. So we always need to be assessing the patient's medications and supplements, even over-the-counter ones. So for vitamin supplements, this is just a general principle. Usually we supplement the water-soluble ones, and we also have specialized supplements with different water-soluble vitamins, B vitamins, and vitamin C. So in clinical care, you may see something called Nephrovite, and that's just a brand that's a specific renal vitamin, so it doesn't have any of the minerals that we're concerned with. And if a patient already has peripheral neuropathy, which is that long-term complication from having diabetes over time, then biotin supplements may be useful. And folic acid supplementation is somewhat controversial, so that's usually not a regular recommendation. At this point, we just don't have sufficient evidence for possible benefits of it. And for mineral supplements, we do not use magnesium supplements for stage 5 CKD patients. However, we do often supplement them with iron and zinc. And we mentioned that different stages of CKD, we also need to watch and manage comorbidities and complications. So one of these is cardiovascular disease. In fact, CVD accounts for half of death in patients on dialysis. So it's not the renal failure per se that kills the patients, but it's cardiovascular disease. And patients with CKD, especially those end-stage CKD patients, have a high prevalence of heart failure, atherosclerosis. And we already mentioned why certain patients will have elevated blood lipid levels. So do remember that a lot of these patients, they have kidney failure because they have diabetes. So, that doesn't help at all either. So many of these patients have accelerated atherogenesis and also elevated inflammation levels as evidenced by increased CRP level in the blood. And we already mentioned the secondary hyperparathyroidism that is common in renal patients. And again, this is because of the compromise of the kidney's ability to activate calcitriol and to reabsorb calcium. So both of these are severely compromised. Therefore, to respond to low calcium levels in the blood, high PTH can only mobilize the calcium from the blood, and this can lead to renal bone disease. And for this reason, renal failure patients on dialysis are usually given an active form of vitamin D to reduce the hyperparathyroidism through feedback inhibition. It's also very common for CKD patients to have microcytic anemia, as we mentioned. We talked about that the reason for this is that the kidneys are responsible in sensing low oxygen status due to anemia. So then in response, the kidneys will release a hormone called erythropoietin, EPO, and this stimulates the red bone marrow to develop erythrocytes or red blood cells, and this can correct the anemia. But in CKD, erythropoietin the secretion of it is compromised or just completely taken out. Therefore, the bone marrow, so the red bone marrow, will not be able to be stimulated to adequately generate enough red blood cells. So red blood cell production will be decreased, and that's why the patients have anemia. On top of that, iron deficiency is not uncommon, so we don't have enough raw material in order to make more red blood cells. So these combined contribute to anemia in renal patients. So in this case, they may be put on, or they will likely be put on EPO treatment, and there's different levels depending on the lab values. So we already talked about how to monitor the anemia by checking different serum levels, so whether it's hemoglobin or serum ferritin, and remember that's a sensitive marker for early detection, so this you should know from previous classes. And for those who need iron supplements, do know that we can give an oral supplement or provide iron through an IV route. So this is standard procedure and is not abnormal to see done.